Okie dokie, I think I'll make a start. Okay, so thank you very much, everyone, for coming to this. It's amazing to see so many people for an event we probably only brought together in the last week. So thank you to Mark Little for the use of his Zoom, but really thank you to everyone for taking the time just to attend this information sharing process. I'm going to talk about the members of this team later in the presentation, but I just wanted to crack on and give you a bit of context about why we're doing this. Then we will discuss what we're actually trying to do, and then we can have a bit of time maybe discussing as a group some of the things that we need to debug, perhaps that we haven't thought of, etc. So what I won't be able to see people's hands or questions. So what I prefer to do is if you just let me ramble on, probably for no more than 5, definitely 10 minutes, and then I'll pick up all the questions at the end. So BronchSTART, what is it about? So the end of 2020, a few people started highlighting that in Australia, in particular Western Australia, they'd started seeing RSV cases, and these are confirmed RSV via PCR, not just clinical cases, within Western Australia. And that I'd spoken to some of the staff there who said it had actually been pretty overwhelming at times, and that they were seeing cases when it was their summer. So if you look at this graph, you can see the red line is 2020, and weeks 51 and 52, which are the end of December in Australia, are clearly the mid of their summer. So we're talking about temperatures 25 to 30 degrees, and seeing peaks of RSV that you clearly would normally see in the winter, as you see on the black line of this graph. And there have been a number of propositions of why that might be the case. But shortly after it went through Western Australia, I then had a conversation with Professor Franz Babel, who was saying not just RSV, is when the lockdown in Australia finished, they started seeing just huge numbers of patients and lots of respiratory patients. And Melbourne is a large emergency department, around 300 a day on average in the winter, but the weekend just after I spoke to Franz, they'd seen 380. So something was happening, which was presumably related to COVID, but we weren't entirely sure why. And then you get a very similar effect, but perhaps not quite as marked, also in France. So you can see from the chart on the left-hand side that there are normal peaks for 2018-19 and 2019-20, and these have been shifted along for 2021. Although interesting on Australia, clearly the numbers were as big, if not bigger than their normal summer surges, whereas in France, the numbers seem to be more comparable, although I do understand that there have been pretty significant PICU utilization in France, as there has been in Australia. So what is the situation in the UK? Well, we've got some pretty robust data from Scotland. And as you can see, if you look through the years, something happens in 2020-21, and it's almost a flat line. There's literally no attendances reported at all. And if we look at the data mart, so this again is a selection of hospitals which report back their PCR positive cases for the viruses that are listed, and RSV is virtually non-existent. If you look at rhinovirus though, and as we all know, in September, October, we get these surge of asthmatics, and this still happened this year. Now, it might not have been quite as big as our normal winter surge, but we certainly in Leicester saw lots of viral wheezers asthmatics presenting in September and October. And so the lockdown process doesn't appear to affect all viruses equally. My understanding, I'm sure some people will correct me if I'm wrong, is that the enveloped viruses, so these are viruses that have a wall around them, seem to be more susceptible to social distancing, hand washing, because the wall more easily pops and the virus is destroyed. But the non-enveloped viruses, such as rhinovirus, are a bit more hardy and resistant to some of the lockdown measures. So we're in a situation where we don't appear to have had an RSV bulge for coming up to 18 months now. And we'd like to know when this will start. Now, this wouldn't have mattered at all if we hadn't have seen the huge peaks in Australia and some other countries, but it does matter because, one, if it happens this summer, that is going to impact on service provision. And this has concerned enough people that NHS England have done a lot of work making sure that there is adequate PICU capacity for a typical winter surge during the summer. So this is a real thing that is taken on board by a lot of people at a very senior level. That what we want to understand, though, and there is some emerging evidence that the patient groups affected by RSV this year, or whenever it starts, will may be different than previous years. So one is there's a whole generation of kids who have not been exposed to RSV, and they will coincide with the newer generation, i.e. the children last year won't have RSV and the children this year won't have RSV. So rather than our normal 0 to 1 criteria, it may be we need to consider bronchiolitis in 0 to 2. Now, traditionally, what we've done is if you're kind of 18 months and older, you're put in this viral wheeze category, but that might make diagnosis more difficult. The other thing is that we don't know how impactful it's going to be. What will the acuity be? Will we see this normal distribution of the large majority of children being clinically well, getting better with no treatment? What proportion will need oxygen and what proportion will need ICU care? Now, we have some understanding of that from previous data. And one of the reasons that we want to do this work prospectively is it would be really useful to find out if the COVID-induced cohort acts differently than previous cohorts. And then the final two things are looking at spread. So there is already some anecdotal evidence in the UK for the tiny numbers of RSV positive PCR cases that we've had, that they have had recent contact with travel, or so I'm told. I've not had that confirmed. And so one of the things that we want to do in our CRF form is collect information on recent travel in the family. And then the other big thing, which might not directly affect emergency departments, but the palivizumab administration process has been delayed and changed because RSV has disappeared. And it will be useful for those dealing with the immunization program to know when the RSV season properly starts, and then when we can start thinking about kind of restarting the immunization campaign. So what we're trying to do is get through a rapid HRA approval process so that we can derogate ethics. We don't want to take consent on every patient. We want to have a process where we can summate data. But even before we do that, because that process will take time, is that we would like people to start recording patients that they're potentially seeing now, so that when the study starts properly, they can be recorded retrospectively. And I will talk to that as a group shortly. I just want to take this opportunity to thank a couple of members of the team. So Thomas Williams is a registrar in Edinburgh. I'll get him to introduce himself shortly, who has been instrumental in bringing this team together and organising some of the data. I would like to thank Mark, as always, but particularly for the speed with which he's produced the REDCap CRF. And then we have a number of study team members who are part of this, who are enabling us to move forward at real pace. So that's kind of where we are. I'm going to stop there, and I will probably stop sharing so I can come back to the screen. Now we have wow, loads of people on the call. That's fantastic. So that's basically the summary. That the plan is going to be is that we create a process by which patients are recruited in real time. Now, we will talk through that process next, but are there any other questions or concerns or queries that people wanted to raise now on anything I've said? And study team members, if I've said anything ridiculous in that presentation, please kind of correct me, especially on my knowledge of viruses. Most people's videos are off, so either if you stick up your hand or stick it in the comments, I will give people 10 or 15 seconds and then I'll move on to the next phase.
Hi, it's Thomas here. As Damien said, I'm one of the paediatric registrars in Edinburgh. I'm also a clinical lecturer at the University of Edinburgh. I'm taking some notes of the meeting. A number of you have put on the chat's comment that you haven't had RSV cases, which is interesting. Those of you who haven't yet done it, could you do that with where you are, and then I can have a record of who's attending the meeting, at least which sites. Thank you.
Oh, that's an excellent suggestion. Thanks, Thomas. Okay. Right, I'm going to take, so Seb's asked a question. Routine measuring of RSV in those older than 1 year, typically not done locally. Should we start for this? Okay, so this is, we have a challenge here that we have done our protocol on and derogation of ethics on the basis that we're not doing anything different in our clinical practice. Now, the way this is going to work is there's going to be some information filled in at the point of contact and then some information within 7 days time. The 7 days time is to find out for those who might be admitted if their PCR has come back positive. Now, I'm not sure we can suggest to trust, and I think even if you did, they might ignore you, that you have to start testing in a slightly wider age group than you normally would do. What I think will happen, though, is that when this RSV season starts again, whenever that might be, I think there may well be a missive for respiratory screens to start anyway in a slightly older age group, because people will realise they might be missed. So I think that will probably happen as per. A lot of people have in Leicester, for example, we do not do any ED testing, and we have virtually banned point of care testing. And the reason we do that is we find that the clinical teams, and it's not normally that the clinicians, it's often either managers or other people, use that against us, so that once they know the status of a child, it can sometimes block their exit from the emergency department until a relative area is sorted for them. So that's why we've not been keen on any point of care testing, although I know a small number of units do that. And we are not suggesting that you should start testing children you would not start on, and certainly children you're sending home. There is a separate, smaller project that will be linked to BronchSTART that might be looking at swabbing all children who present with symptoms to work out who might actually have it, because I think that is an important question, but that is not part of this study. Please do not start swabbing children you wouldn't normally do just for the purposes of this. I hope that kind of makes things clearer, Seb. Okay, so what I'm going to go through quickly then is the design. So essentially, as I'd said, so Mark has created a very thorough and pretty easy to use REDCap form. So our expectation is that a child would arrive. If you think that they clinically meet the case definition, which is children with respiratory symptomology, but who are not a repeated attendance or have recurrent wheeze. So this might be broader than your definition of specific bronchiolitis. The reason we're doing that is because we want all comers, essentially, and that we don't know how many children who may be admitted who you're not sure about bronchiolitis do end up being RSV positive if they do have swabs. and we're not sure what the lay of the land is going to look like. So that's why we've gone for a more lower respiratory tract infection definition rather than a specific bronchiolitic definition. But you see that child, and what you do is hopefully you'll have a local book, like many people did for the PERUKI and children's study, where you'll write down your local hospital number and the patient study identifier. So you'll all be given a study name, and then you'll have numbers for your particular study. So for Leicester example, our first patient will be LEI001 and going on. But on that first presentation, on the red cap form that hopefully all of your staff will have access to, that person will fill in quite quickly LE001 and will fill in details about the child, a general age, their clinical symptoms, whether they've had any kind of recent travel or contacts, their family, siblings, and then what you did with them, were they discharged or admitted. And then within 7 days, in 7 days time, you'll get an email, because this will all be automated, to ask you to fill in the detail that you might not have had at that initial presentation, which will be things like, were the child admitted, what their PCR test was, if it was taken, etc. And that's how we will go on. Now, the sheet of paper that you record is the place that you use to work out what the S number for the child was, so you can fill in what happened to them. But that sheet of paper, because it could just stay in your department, you could start filling in that now, really. Now, it can't really contain clinical data, but it might enable you to, if we could start essentially, all of us, this Monday, by at least recording the patients who come in with the case definition, because then when we start the study properly, you can just go backwards and fill in all that data, and then we're not missing patients. So I hope that makes some form of sense. Mark, would you be able to get the CRFs up, or do you?
Yeah, I'll just pull it up now. So I'll just pull up the electronic version. So the concept behind the CRF is really to accurately collect the data that we're sometimes not as good at documenting as others. So there's some stuff which is hard and fast, there's some stuff which is captured electronically. But there are some data that we may chat through with parents but not always document. And that then can make it challenging whenever you want to go back through the notes to try and pull out the information which may be relevant based on what Damien was saying earlier in terms of the contributory factors. So the idea was to try and capture as much of that on the CRF as possible, and to do that really as live as possible. And the idea was to put this into people's pockets, so to put it on their phone, which is why we've come up with the Red Cap survey tool. So it is a generic link that everybody can submit a new form for every patient that they see that fits the clinical diagnosis. So you can have this link on your phone, you can have a QR code in your department that people scan and it'll navigate them to it. The idea was to try and keep the amount of information collected in this small and just to the really important stuff in order to remain nimble and not to overburden clinical teams while they were trying to wade through a waiting room full of bronchiolitis. So I don't know whether we've got it right or not. I know that many of you have had a look at this and there have been various questions coming through. The other thing is to try and make it as tick boxy as possible for analysis purposes, free text, kill, things like this. So this is the first time we've really kind of pushed, pardon me, the elements of the CRF into people's pockets. It's building on what we did with the PERUKI and children's study. It is also possible to send you through the PDF that you can have printed out. If it works easier for you to put it on paper and have someone submit it all afterwards, that's absolutely fine as well. If you can be absolutely guaranteed that people definitely collect this information whenever they're seeing patients and document it, again, you can actually have somebody in the team who's badged to fill in survey form after survey form after survey form. It also collects the key information that we need to be able to send out the second CRF at 7 days. So it's got the introductory text. Most people will ignore this most of the time, but it just says basically if you're doing it and you're halfway through a shift, please remember the code because you might need to come back and fill in the end of it. There's an eligibility check at the beginning. I'll just zoom out slightly on this so as you can see it all. So we just need to make sure that they do actually fulfill the criteria for participation. If they do, then you'll get the green box. If they don't, then you'll get the red box that says, no, it's okay, we don't need this one, thanks very much. You'll enter your site code number. So if we take BRI 0001, and this is my name, it's just your first name we need. The only reason that we collect that is because when the follow-up form comes through at 7 days, it will then say, hi Mark, this is just your email to tell you that you submitted a patient. And then the email that we use for work-related purposes. I'm actually going to enter my Gmail one here, otherwise I'll not be able to see. That's not me, that's me. Somebody called mdlittle@gmail.com, I'm sure gets a lot of crap. Okay, so these are the basic details, attendance and patient details. The patient is here today, so we've left that button on. The child is 5 months. Depending on what you answer to this, you may get a secondary question that pops up because we need a little bit more detail about those. Male child, do they have any comorbidities? None. What you cannot do is select that one and that one. It'll give you a warning. You can override all these warnings, but we're trying to minimize data conflicts as far as possible. So we're going to say no comorbidities. We want to know how many siblings the child has, very Dropboxy, and have they traveled away? Yes brings up more questions. Adaptive logic brings back more. And you can see at the bottom, there's the save and return button that you can access at any point. For example, there you can see that. That's my return code. That's what I need to remember. But actually, I'm just going to go back and finish it off. So we've got that information so far. We'll go on to the next page. First recorded oxygen saturation level. At certain levels, warnings will pop up. At other levels, it'll be absolutely fine. First recorded rest rate. And blood gas. So you see it's outside the range, but it'll still let me enter it. It'll just ask me, am I absolutely sure? If I've done any testing, whether it's point of care or blood gases, that will trigger more questions, but I'm going to say none, just to speed things along. And child require any of the following. If you tick these again, there's some adaptive logic on there, but none for the sake of today. And then a question about what happened at the point of discharge. So we're going to say discharged home. That's the end of the CRF. So if you know your patient, you can rattle through that in under a minute probably. And that's where we wanted to get it to with the CRF, so that it made it realistic to put it in people's hands in the emergency department. Once that's submitted, it'll then sit in the system and 7 days later send out another email to ask what then happened to the child. I'll just see if I can generate this coming through. And if I go to my Gmail, we'll see if the magic has happened. I don't think I've changed anything in here recently. So it's now sent through my follow-up email. And we've tried to put in some information in here. So we've included the participant number so that I can go back and check and get the local hospital number and look for all the results that are in here. And I can see that they attended on the 15th of April. There'll be some validation around this, but for today, I'm just going to use that date and go to the next page. And this is where we're going to try and collect the information that is more hardwired in the system. So the like of the PCR results from the labs, the IMD score for the patient's postcode. This at the minute just works for England for IMD deciles based on 2015 data. This is with the kind permission of Duncan Appleby. Anybody who did the FORCE trial will know this website. He's agreed to loan us use of that, and we're looking at whether we can find something that works for Scotland, rather, Wales and Northern Ireland, and potentially in Ireland. So it'll ask me questions specifically about that 7 days. And it's important to remember that this is 7 days after the attendance, not the day that you're filling it in necessarily. It'll ask me whether they're at home or on a ward or whatever else. It'll ask me a little bit about the patient journey as well. So I'll need to know from looking through the notes. Now this is triggered to go to the email address which is entered in CRF1. So I know some sites have asked the question, can this form go to a single named person? That's absolutely fine. I can set that within the system. And you can also set that at site as well. So say, for example, in Leicester, if all forms are to go to Damien, then all the site have to do is enter his email address every time rather than their own, and he will receive every single form at 7 days after follow-up. You can see I'm just throwing down a few options here, and that again is it. There are no more questions. That's the end of the data entry. So it's relatively data light because we're aware that A, the first form is going to be completed hopefully during the patient attendance when the department might be busy, but also that the numbers for this could, if we follow the Western Australia experience or the Melbourne experience, the numbers could really be quite big. And so we want to streamline things as much as possible while still trying to get all the relevant information out. So I'm just going to press submit there. I could see a couple of orange buttons flashing up at the top. You can see because I have not completed something compulsory there, then it's going to tell me off, but I'm going to say that's okay anyway. And I will stop sharing and see if there are any questions in the chat or any other comments on that.
Cool. Yeah, so there's thanks everyone. There's a couple of questions that have come through. So Stuart wasn't clear what was meant by local environment with respect to travel history. Now I think what we meant by that was kind of the area in the local environment, as in the COVID standard, i.e. you've not been out of area. I know that's a bit woolly. I don't know, Olivia or Thomas, you had any particular comments or definitions on that? I think that's what we meant, is if you've not traveled anywhere outside you would normally be allowed to as part of pandemic rules.
I think that's a fair assessment. Clearly, it wouldn't be standard practice necessarily to ask that question, but in the early stages of what's like to be a delayed RSV season, it might be quite interesting to know that and ask more detail than you would do normally about travel, because it could be that cases are coming in from particular parts of the country.
Yeah, okay. Stuart, does that help?
Yeah, absolutely. I just think that will need to be explicit because there's going to be a lot of different people filling this in for the first time, and I think the same question will pop up. I mean, I guess it's relevant if we go back into any kind of lockdown, but right now, given the relative lack of restrictions, that would, I assume, only mean travel abroad, because right now we can cross borders between England, Wales, Scotland. So if you're using the COVID restriction definition, then at the moment, if nothing changed, it would only mean travel abroad.
Yeah. Okay. There's 2 points there, Stuart. So one, Mark, we just need to think about the wording that we use there. So maybe local environment isn't clear enough, and we need to have something that's better worded, but also about how much we need that. Olivia, I see you've got your hand up.
Yeah, I was just going to say, I think that it's really helpful to get feedback about the questions that are less clear. And I think this is one that we had a bit of discussion with when we were discussing with Liz Whitaker, and it came up at the beginning of this. I think partly is how much can we expect people to ask in addition about travel history? And I know that we all should be doing it in terms of exposure for respiratory illnesses and things. And then secondly, exactly as you say, trying to kind of make it a bit more solid. So potentially something more like, have you been outside of your county, or have you been outside of your country, or have you been outside of Europe, would make it probably a lot more solid, and would also, therefore, whilst we're all at the mercy of the COVID rules changing, but actually you'd have some consistency throughout.
So I think that that county country is probably the way to go. Mark, can we make a note of that? Because I think that's probably the easiest way to deal with that particular question. Okay. Now so Sally, I know you've got your hand up, but while it's in my head, There's a couple of times where there's a perceived difference between received oxygen and required oxygen. And my feeling is it should be whether you've physically been given oxygen or not. If your SATs happen to be 56% and no one chose to give you oxygen, that's your local clinical issue. So it's what the SATs were and whether you were in oxygen or not. I think we should, Mark, it might just be worth checking that's clear and standardized, because I think Richard Burridge has pointed out that there might be something else about that at the end. Okay, so we've done that. I've got a question. So I'll go to you next, Sally, and then I'll go back to Caroline's question.
Hi, thank you. Sally Gibbs from Sheffield Children's. It was just taking me too long to type, so I thought I'll just talk, if that's all right.
That's fine. No worries at all.
So the form looks really simple to fill in. I think it would capture the sort of ED history and, you know, things that you'd have to hand. I guess I just have a query about if there are things that people haven't asked in the history. And I guess the things that I thought they might not is number of siblings and maybe some of this specifics around travel. Can people bypass that field, or would it mean that the whole form wouldn't get filled in, if that makes sense?
Yeah, no. So you can miss them out.
Okay.
It's not ideal.
Yeah.
The more and better information we can get, we'd like. I think, and we discussed this as a group. I mean, there's a way of going, you have to collect the information because then you've got it on all patients. And the moment people realize that they can miss stuff, it becomes problematic. What I think we might do, that you could consider this cheeky of us, we might, when we do go into the surge, we might start auditing that response rate per department. And I think if there are some departments that are just letting it go, we might give them a friendly nudge.
Yeah,
Is that a reasonable way to go?
I can just see that if there's something people haven't asked, they might choose to just scratch the whole form rather than go back, you know, if they're busy. So that's helpful, thank you. And then my other question was, is this through ED only? Because certainly our setup is we've got a co-located assessment unit, so some kids with the same presentations will come via a GP and then into an assessment unit. Should we include them, or is it just the ED?
So if it's the first place that they've been seen, and that you've not got another emergency department with you that could also be collecting data so that we could get confused, that would be reasonable. What I don't think you can, I think it will be difficult for us to have, if you see some patients directly, but also you've got an ED and they refer to you, that would get confusing. But if there are, I think it's Gloucester, they have no kids ED anymore. Everyone just goes to their assessment unit. The assessment unit might as well be the completing site. Does that make sense?
Okay. Yeah. So we've got a single front door, so kids get triaged no matter which route they've come through. But then if they've been referred by a GP, they go left instead of right. If that makes sense.
Okay. I think we can. I'm going to have to think that through with members of the team. We'll get back to you ASAP about that. One of the things is that many of you may also either be a member of PERUKI or be associated with PERUKI. For a number of reasons, this isn't a PERUKI and PERUKI study, i.e. it's not general pediatrics and ED, it really was aimed at ED. It's clearly becoming apparent over time that there is this merge of the single front door process. And I think this is one of those first studies to really put that Venn diagram together. We've probably not done that perfectly, but that's a state for this particular study, and we can think about kind of changing things moving forward. Okay, so Stuart's got another comment. There was a comment on Caroline, yes. The IMD code applicable to England, would we still include patients from Wales, which accounts for about 20% of our patients? Mark, is that England and Wales, or is it just England for the postcode at the moment?
Mark just emailed me to say he can hear us and see us, but he can't actually respond in any way.
Oh.
But he will think about that and then email me and I can update you.
So, we'll wait for Mark's comment on that one.
Damien, it's Julianne from Belfast. The IMD code only works for England. So Scotland, Wales and Northern Ireland have different systems, which she's working on, because whenever we put in postcodes from Northern Ireland, it didn't work. So there'll be a workaround from that, and then we can input data later, was the current work through for us in Northern Ireland.
Excellent. Okay, thanks, Julianne. Someone just made a comment about working on standard NHS computers. That's from Rachel. Our experience has enforced that it didn't. It worked kind of virtually every time, so I don't think that will be an issue. Niall, does the entry out of acute lurgy include presumed bacterial cap? Yes, it would, because you wouldn't. So I think if that patient needs to be included if you think that they've got respiratory distress and they're being admitted, because we might find some of those are actually RSV positive rather than true pneumonias. That's right, isn't it, team? Don't shoot me down if I said something. Olivia and Thomas? Yeah, okay, they're agreeing. Good. And Stuart, do you had another comment that you wanted to bring up?
Cheers, Damien. It's more just to share my thoughts about how things are going to work in Birmingham, to see if any other sites are thinking the same. So CRF1 I love. I think the concept of having it available on your phone is brilliant, and getting as many people involved I think will be very, very worthwhile. Challenges to that are probably going to be people like locums who just pop into the department, but hopefully with enough kind of promotional material around the department we can overcome that. My main concern at the moment, thinking about how this is going to work in Birmingham, is CRF2. Two things I'm thinking about is, number one, how we get some of this information, and number two, who completes it. When I reviewed this study, I think I can convince everyone in my department to complete CRF1. I know that people will not pick up emails, will not respond when they're next on shift, will not have the time, will not be permitted to take time out of busy clinical shifts to do this. So I'm probably going to go down a route of having a small number of individuals who will fill in all the follow-up data. But in my own site, I still don't know for certain how easy some of this is. I'm trying to understand what is contained in the discharge summaries from General Peds to see if that will help us. My fear is that this is going to require having to pull hospital notes, which I know will probably be a big barrier if we suddenly got boxes and boxes of notes having to come to ED to find out whether a kid has an NG feed or that type of thing. So I'm just curious to know if other people are thinking similar, or have other departments got far more sophisticated systems, which means they can get this data electronically, or is everyone else having the same puzzle about inpatient info?
Okay, thanks, Stuart. Your question also coincided with a question from Caroline about this being on the portfolio. I'm doing everything in my power to get this onto the portfolio. And in fact, that has been one of the delays with getting this to ethics, because I've got a local sponsorship issue. Our trust are really keen to sponsor this, and that they see the power of this being on the portfolio. So they want some weights and measures so that we can stick it on IRAS as a portfolio study from the outset. Because if we can get research nurse support or other available support for people to do the CRF2, then I think that alleviates some of your concerns. For some of the electronic records, we'd have access to the PCR results and where the patient has been just from our nerve center system, which isn't even a proper EPR. I'm just able to see where the patient's gone because I have access to the discharge summary, where the patient was in the hospital after the ED, and microbiology results. I hadn't considered that might not be easily accessible to other sites. I thought most sites would have that. I mean, in the fine detail of NG feeds, etc., I get might be a bit challenging. But I might need to think about that. It would be useful, I think, Stuart, for you to break down which of the elements on the form 2 that you think you will have most difficulty with. And we can put our kind of thinking caps on about how we might help with that or alleviate that demand from the CRF. Does that make sense?
Just picking up on this point, Damien, this is Sheena here just from Dublin. I chased blood results or NPA results done on a child last Friday, and they're not back yet. And this is the joys of COVID, and we sending off our NPAs to the virus reference lab and then being focused on COVID. So even us having results within 7 days currently aren't achievable, whereby they are in process, but they might not be back. And one of the other things that might be considered is on the children who are recruiting in the emergency department, sending a single sheet to the inpatient team to get them to fill out and just tick box what they do for treatments. Because we, like Stuart, don't have an electronic discharge template that we can look up. It's chart based. And this is where we got our inpatient buy-in as part of agreeing to sign up to this project.
Brilliant, thanks, Sheena. That's really interesting, especially about results being available within 7 days, which I hadn't actually considered, but I do get is actually, especially if you were admitted or you were sent home, return, were then admitted, and you'd only had a swab done maybe 2 days previously. So, okay, that is something for us to just digest. I mean, the 7 days is just to get to have a line in the sand, but it doesn't have to be completed on that 7th day. We just need the information available. So I think we're probably going to have to include some minor mitigation for that. Okay.
Damien, can I ask a quick question?
Yeah.
I'm just looking at CRF1 and CRF2. So let's say a doctor has I've seen a patient and you generate a code and that patient's details are inserted. And then you get a second email, for example, later on to say that this, can you fill in the details 7 days after? How do you link the second email with the first patient? Because the CRF is only asking you for non-identifiable details. So so if, let's say, I've seen the patient on day 1.
The local study number.
Okay.
Because so, to the first presentation, you'll get your LEI 001. You then get that email back, and for the you can look up the details. This is so the thing that we've had to do to bypass kind of governance restrictions is that you may need to go back to your department to look through the list of study numbers to find your local hospital identifier to get the information that you need.
Yeah, it almost looks like you've got to have a sheet of paper or like a research box where you actually have the name of the patient and hospital number and then what the research number is.
Yes. And
you have that in the department.
Yeah, you have to have that. Sorry, maybe I didn't make that clear at the beginning. That is exactly what everyone is going to have to do. But what we're proposing, though, is you could start using that sheet of paper from today almost. Now, one of the things I wanted to discuss as a group, appreciating we've only got 15 minutes left, is I was going to start that in our department on Monday. And literally, people, all they need to write down, there's no other thing is other than I'll do the pre-done study numbers. People will write down the hospital number and details and date they saw the child. And we'll just start recording because we can then go back into the notes of those patients. We won't have all the information that we need, but we'll have enough that we can submit into the CRF.
Mm-hmm.
Okay. Now, so spreadsheet we've already sent around, so you should have that sheet already, I think. Will there be a way to get to the details of patients who have got incomplete CR2 forms, even if our email address isn't put in? Mark, I will get, I think you can hear, hopefully you can respond to that on the comments if we can't hear you. Now, is there a time frame? Okay, so this is a really good question. Is there a proposed end date? Yeah, it's essentially a year. There is a possibility, I suppose, that we've got this completely wrong and that we don't see RSV during the summer. So it doesn't come back in the way that Australia and other countries would predict. Everything stays flat. We get towards the winter, and then for whatever reason, we go back into some partial lockdown, and that we're all just waiting there for these patients for some ridiculously long period of time. And I don't know what we're going to do if that happens. But for the moment, we've put the study end date as, I think it was March 2022, or about a year from now, basically. Again, Thomas, you've just been through the protocol. I can't remember what we'd said. I should know that off the top of my head.
Yeah, I think we put a year, and I think one of the really nice things about this study is it provides data for clinicians in real time to give you a feel for what's going around the country, because even from this call we can see that from the 30-something centres there's been 7 RSV cases, which we just wouldn't have been able to get otherwise. And secondly, the data that we're gathering is not being collected anywhere else. There's no other centres in the world gathering this in real time and being able to release it in real time, and that'll be really interesting both for ourselves and for other countries who might see delayed peaks or different peaks. And it's just nice to have that level of data and to understand whether RSV is becoming less common, whether the spectrum of disease is changing, whether we can expect unusual seasons for several years. So yeah, just to emphasize that it's a really unique way to be able to collect and release this data.
Brilliant. Thanks, Thomas. Final question. So is there an opt-out for parents? So we are submitting that because this is data that is normally collected, and that's why so while you might not collect a travel history, technically you should do, or the infectious diseases consultants in your institution will tell you should be doing if they've not done already. So that there's nothing new that you wouldn't normally do. This is normally collected data, that nothing is happening to the patient. So we are quietly confident that we won't need a formal consent process. Now, obviously, if that becomes a real battle, we're going to have to review things. But my real hope is that that we will get away with that. How will the real-time data be shared? So that is a good question. We will have essentially geographically identifiable data, i.e. by site, on the REDCap form, and that we will be able to pull down some graphical representation from REDCap because it has some kind of basic display software, and we will monitor that relatively quickly. I mean, even just from this call, I mean, as Thomas has just said, we've got quite a broad range of emergency departments with a small cluster of, technically anecdotal, but I can't believe people are just making up that they've seen cases and what their PCR results are. So for all intents and purposes, that probably is true. So that we already know, well, this is starting and there are positive patients. The weekly surveillance on the NHS data website run by Resmart is only a certain section of hospitals. We will be able to validate that work and vice versa. But I think we are going to be a lot more responsive. And the one thing that we have that the data mart doesn't have is literally they are just reporting PCR positive results. They could be taken anywhere off any child, whereas we will have what the acuity of the patients is. And I think that's going to be one of the real big things for this study, because we will know quite soon if these patients are ending up being admitted and spending a long time in hospital, or as has been found in some of the, I think in some other countries, that actually the majority of patients may be quite mild, for example. We just don't know. So I think that's going to be a really interesting real-time finding from this study. Oh yeah, so yes, so Neil, there is also the ECGS that just looks at coding for bronchiolitis. Now that will be, we can compare to that as well. We think that we are going a bit broader, so our results might be a bit wider than the ECDS view, but between you and me, the ECDS isn't quite as functional nationally as people would like to believe, and its reporting system won't be as robust as this particular study. How do we get permission for collection of data? Yes. So one of the things that sites might need to do as a local governance is just submit this as a service evaluation audit type procedure, just to be able to collect the data locally. We had no problems for that for previous PERUKI studies or any project I've been involved in. So I'm hoping that's not a big issue.
Hi, Damien. Sorry, just one comment on that. That the only thing that's slightly different here is we're talking about portfolio adoption and maybe support from CRN nurses. Now, previously, when we've had service evaluations, it's all very much been in-house. But I've never had a situation before where I've logged a project like this with audit, but then said, now can I have some R&D nurses to come and give me a hand?
So, Mark, yeah, no, I think that's a great point, Stuart. What I would suggest is now, so there's two ways of doing this. The completely squeaky clean way is to submit to audit just because you want to start collecting data because you've got a list in your department as soon as possible. But as soon as we get HRA approval and it goes over to the evaluation, that audit then closes and is moved on to the HRA. The other thing, and I will be careful with my wording here because I know I'm being recorded, is that knowing that we're hopefully likely to get HRA approval and that you're very careful with the form in your emergency department, you just proceed. Okay. Excellent. So we've got 5 minutes to go. I think questions are starting to run out. Can I just express my immense gratitude and pride in everyone for the amount of people on this call and the interest shown. It's really kind of enlightening given the year that everyone's had, that we're all really still interested in topics like this. And it's really nice to see the interest that can be generated. So thank you all. It's certainly made my day. Is there any other questions before we finish?
Hi, Damien, Richard from West Herts, Watford here. We were sort of sitting on the fence on this one with our sort of concerns about not having an EPR and whether we're going to be able to do this. My gut feeling is that we should give it a go, and I think we'll try and find a way to make it work. What do we need from your end? What do we need to do to sort of say yes at this stage, that we'll get involved, or do I just need to email you guys and go from there?
Yeah, so from the original expressions of interest, did you put that you were keen to be involved or that you were unsure?
That's a good question, because my colleague did it. One of those. We certainly didn't say yes. We said maybe. Okay.
So the process is that everyone who said yes will start being contacted by the group. We will get in contact. The maybes we are going to follow up. So hopefully you would be included in that. We've already, it looks like we've got 30 plus sites already keen to go, which is a great amount. My suspicion is if we can get it onto the portfolio, it'll go even bigger. But by whatever route we will reach out to you. Certainly feel free to bug me via email if you don't hear anything. There's a really interesting comment from Stuart to Mark. I think what we'll get Mark to answer that separately, because we're going to need to do some thinking about the technology of REDCap. And is there a minimum number expected for data? No. Now, it'll be interesting to see whether we get pushed from the HRA process. So we've come up with some speculative numbers we might get, which I think are realistic for the whole study, but we wouldn't put down a minimum number for each site. Now, if we are adopted on the portfolio, one of the weird things is that you will be asked how many you will get. Now, we don't know that until the bronchiolitis wave starts. And I'm not sure that this is this has ever been tried in a study before, because it might not be your fault that you've not got any for a period of time. So I'll need to work that through. So I'll get back to you on that question, Rachel. And yeah, Kate, being able to use tags, we've lots of people for force, for pick. I think having stickers or having aid memoirs to alert people will be really good. And yes, if anyone's on this call but don't think they've expressed an interest, please let us know and we'll follow up on that.
And Damien, do you want to mention the study protocol we're about to submit?
Yes, that's a great, well done. This is why I constantly need kind of poking and reminding. So Thomas has really kindly pulled together a submittable form of a protocol that is going to go hopefully for publication. What we would like to do is name all the sites who have been interested in taking part, and we can list those on the publication, which I'm hopefully is useful for people's portfolios. So if there is if that's a little bit of a carrot for being a part of this, I'd like to know if anyone's got any objections to doing that. I can't see why you would, but if you're kind of wavering about being part and that may be the thing that helps you make that decision, let us know ASAP. Perhaps we'll give you kind of 24 hours or so, but we are hoping to submit that protocol ASAP. It will really add to the kind of the validation and will help some of the HRA approval work if we can get that published. Excellent. My suspicion is there probably are some other questions. It may well be that people can't put comments in or their audio isn't working. As I said, if you've got something that we've not covered, can you please just email that? We have recorded this session so that you can share this meeting with your colleagues, and we can share them with some of the sites who, for very justifiable reasons, haven't been able to attend. But it just leaves me to thank the study team again. Thank you for pitching up in such high numbers. I'm really excited about this study because I think it is something that will put us on the map on a real national stage, because I don't think there is any other country that is going to be able to do this because they've either had the wave already and have missed their opportunity, or they're just not geared up in the way that we are to do this type of research. So really exciting. Excellent. Well, thank you for your time. We will be in contact with kind of next phases with permissions. But if you are able to start just using the form that we've already sent round to start collecting patients from as soon as possible, preferably on Monday, that would be great.